Hello, this is Standing Committee on Health and Social Development for our afternoon session. Just wanted to, I didn't introduce the committee members before, so we have Zach Bell, Heath McDonald, Hannah Bell, Sydney McEwen in for Brad Trivers, Tricia Altez, and Ola Hammerlin is joining us here today. So can I get an adoption of the agenda motion? Hannah Bell. So we're having a briefing on supervised consumption sites and harm reduction. So I'll pass it over to our guests to introduce themselves for Hansard and then go with their presentation, and then we'll ask questions at the end. Thank you very much.
Hi, good afternoon. Hi, good to see everyone again. I'm Heather Morrison, and I'm the Chief Public Health Officer, Department of Health and Wellness here in PEI.
And I'm Erin Bentley. I'm the Senior Public Health Policy and Planning Officer for the Chief Public Health Office.
Okay, excellent.
I know it was just a few weeks ago we were here, and I went home that day and I mentioned that to my children. I'd been at a standing committee, and I said it went, a fairly long time, and they said, "Oh, were you tired of standing?" I said, "No, I didn't stand." And they said, "Well, did they all stand?" I said, "No, they didn't stand either." So they asked me the same question when they found out I was coming back here. Was I planning to stand today? So I'm glad we're all seated. Yeah, exactly.
Let's do it. Squats.
Good to see everybody. So really a focus, we'll try to touch on a number of areas related to problematic substance use and harm reduction. So as we did last time, just obviously trying to situate why we would be involved with this with the Chief Public Health Office. And our mandate is to protect and promote the health of all islanders. And the areas that we work on include surveillance, policy and legislation, education and awareness, research, and we have really everything from vaccines to tobacco cessation in there. In terms of the substances that our office has been involved with and interested in, tobacco, alcohol, vaping, cannabis, opioids, and as well as the relationship to sexually transmitted and bloodborne infections as well. In 2017, substance use cost islanders $248 million, and 66% of those costs were due to alcohol and tobacco. And this is from the Canadian Substance Use Costs and Harms Project, which estimates the cost of substance use in Canada. And it is really from a partnership between the Canadian Centre on Substance Use and Addiction and Canadian Institute for Substance Use Research. And these estimates are really costs across healthcare, lost productivity, criminal justice, and other direct costs. And they use an attributable fraction approach, which equals the estimates, which estimates the proportions of different types of illness or injury that can be attributed to the use of a particular substance. So the attributable fraction of lung cancer to tobacco use, for instance, and accidental cannabis poisoning would be some examples. So overall, in PEI, according to the Canadian Substance Use Costs and Harms working group that came out in 2020, $94.3 million were costs related to alcohol, 68.7 for tobacco, 18.7 for cannabis, 29.3 for opioids, and 37 million for other substances, and that would include cocaine, other stimulants, and other depressants. Again, from the same source, with the Canadian Substance Use Costs and Harms Project, in 2017, substance use attributed healthcare costs, so these are taken out of the previous slide, healthcare costs were estimated to be $70.7 million, and 86% of these costs were due to alcohol and tobacco. And when we talk about healthcare costs, that includes inpatient hospitalizations, day surgeries, emergency department visits, specialized treatment for substance use disorders, physician time and prescription drugs, and alcohol and tobacco together are $60.5 million. There was $123.6 million in lost productivity costs, and this includes premature mortality, long-term disability, as well as short-term disability, and $39.9 million in criminal justice costs. The $13.8 million in other direct costs is really around research, fire damage, motor vehicle damage. Emergency department visits for substance use-related health condition in 2017. Per 100,000 population, alcohol had 2,221 visits per 100,000, tobacco 829 visits per 100,000, cannabis 105 visits per 100,000, opioids 150 visits per 100,000, and other substances 283 visits per 100,000. And again, this is all from the report out last year. And we get asked the question, really, why harm reduction? And this is from Health Canada. Evidence shows that harm reduction is a vital part of a comprehensive, compassionate, and collaborative public health approach to substance use disorder. And I'm sure that's familiar with for many in this room, but I think it's worth talking about why we're speaking about that broad harm reduction, which is a set of policies and programs and services, as well as actions to reduce the harm to individuals, communities, and societies related to drugs, and that's out of the World Health Organization. And it includes a range of things from needle exchange to opioid substitution therapy, as well as prevention and management of HIV, viral hepatitis, TB, mental health conditions, sexual and reproductive health interventions, provision of naloxone, and training on overdose prevention for people who use drugs in the community. Some of you will remember the release in October 2017 of PEI's Action Plan to prevent and mitigate opioid-related overdoses and deaths. And opioids are drugs that are mostly prescribed to relieve moderate to severe pain and are known to elicit a sense of euphoria. Opioids vary in their potency, and they also possess highly addictive properties. The PEI Plan to prevent and mitigate opioid-related overdoses and deaths, our action plan, was developed in response to increasing number of overdoses related to opiates, as well as opiate deaths in some parts of Canada, and the concern at the time that PEI might experience the same increases. And so when we started in the fall of 2016, looking at this and analyzing the information out of the Chief Public Health Office, our indication at that time was that it wasn't a current public health crisis at that time, but we were concerned and wanted to monitor the impact of overdoses and deaths in PEI and try to mitigate them as best we could. So the action plan builds on previous work PEI had done to address opioids and opioid use disorder over the past decade. And some of those examples would be the drug information system that has been well in place for some time, the opioid replacement therapy clinics, the needle exchange program, and passing the Narcotic Safety and Awareness Act, and expanding access to Suboxone, for instance. The scope of the action plan was establishing the opioid overdoses and death surveillance, and developing a rapid response protocol using the surveillance data to determine if there had been an increase in opioid-related overdoses and deaths. There was harm reduction component with including expanding distribution of naloxone, enhancing communications and education, and enhancing opioid replacement therapy delivery. There was collaboration on the supply, so establishing a formal prescription monitoring program to review trends on opioid prescriptions and share with colleges and associations to support the education of clinicians, initiate public reporting of trends, design and implement processes to identify and respond to questionable client or clinician behavior. And also underlying these different scopes of the action plan were the considerations specifically identified as requiring further attention during the development of the action plan around pain management and education and early intervention for youth. The national situation, and this is based on data up to June of 2020, which is really what has been released formally nationally. Since 2016, there have been over 17,600 apparent opioid toxicity deaths across Canada. And the COVID-19 pandemic has, by the numbers, has worsened the opioid crisis. Over 1,600 deaths were reported in the country between April and June of 2020, the highest quarterly count since national surveillance began in 2016. While Western Canada continues to be the most impacted region of the country since 2016, rates have increased in other Canadian regions, including Ontario. 75% of accidental apparent opioid toxicity deaths in the country involve fentanyl in 2020, and that's from January to June of 2020. We have been doing a weekly surveillance of overdoses via PEI's trauma registry, and there's quarterly surveillance of deaths in collaboration with our lab, pathology, and the Chief Coroner's Office. We do not include intentional overdoses and deaths. These are unintentional or accidental overdoses and deaths. Data is limited, but overdoses involving fentanyl are numerically higher this year than in previous years. And more than 95% of cases, both fatal and non-fatal, reported involve mixed toxicology. And that's where there's a mix of opioids as well as other substances. Overdose surveillance began in May 2017. Therefore, we did not have data for 2016 and up to April of 2017. Deaths are reported with at least a 3-month lag, and that is due to the time it takes for death investigations, and only closed cases are usually reported. Death data is reported to the Public Health Agency of Canada and the Special Advisory Committee on the Opioid Epidemic on a quarterly basis. Between January 2016, when our surveillance for deaths began, to September 30th, 2020, which is our most recent reporting period, males and females almost equally represented among accidental opioid-related deaths. And those aged 40 to 59 made up over 50% of deaths. Of the 29 accidental deaths on record since 2016, 5 involved fentanyl. All but 1 death were of mixed toxicology, where it, as I mentioned, also involved 1 or more non-opioid substances. And these are our non-fatal opioid overdoses, which total 56. Between May of 2017, when our surveillance began, to December 31st, 2020, and our data for 2020 may be slightly incomplete, but if we find out more, we add it. Males accounted for the majority of accidental overdoses not resulting in death, and most overdoses not resulting in death occurred among those aged 20 to 29 years of age. Of the 56 accidental overdoses reported since May 2017, 10 involved fentanyl, and 9 of these occurred since May of last year. To date, 96% are of mixed toxicology. The last public health alert was issued on October 3rd, 2020. And this is also part of that action plan where we develop a rapid response protocol, and we have worked in conjunction with our police services, coroner, as well as our partners to make sure that we have a rapid response protocol in place, and part of that is to issue an alert. That was sort of some of this epidemiology and surveillance. I'm moving into some needle exchange program information. There are 7 sites across the province. It's staffed by public health nurses from Health PEI. Summerside, Charlottetown, and Montague have the most consistent clients, and O'Leary, Alberton, and Surrey occasionally have clients. All sites remain available. And the services offered are clean syringes, needles, injection supplies, but also safer sex information, condoms and lubricant, immunizations, safer injection and wound care education, naloxone kits, resource referrals, and information for living well with hepatitis B and C, HIV, and other sexually transmitted diseases, as well as used sharps collection. The Needle Exchange Program is a program that I feel has been underfunded in the last number of years, and due to its success requires more and more dollars each year to run. The number of needles in and out has increased each year. In 2015, limits on the number of supplies given at one visit was lifted. So we now see between 800 and 1,000 visits each year with increased distribution year over year. The Needle Exchange Program extension sites is what we want to talk about here. It's just a slide to talk about, since in August 2020, the Department of Health and Wellness partnered with Peers Alliance to offer an extension of the NEP, which is being piloted to provide increased access to clean supplies. So there are 2 extra sites with increased hours, and that's at the Peers Alliance office as well as Outreach Center. And between August and December 2020, 683 kits were distributed containing 13,360 needles. 65 to 70% of clients identify as men, most are in their 30s or 40s, and most are returning clients at the Community Outreach Center. So I think the NEP extension sites do have extended hours, with the Peers Alliance office open until 5 p.m. most days, and the Outreach Center 8 a.m. to 8 p.m. with safe supply kits available. The naloxone take-home kits, we started distributing in June 2017 at NEP sites across the island at no cost to clients. In August 2017, kits were distributed to other services to provide to clients. So naloxone kits are now available in many services, community mental health, our addiction facilities, Queen Street Recovery Clinic, provincial corrections, emergency departments, the Strength Program, provincial group homes, Peers Alliance, Community Outreach, and Abegoit Health Center. Since the beginning of the program, 1,800 kits have been distributed. The naloxone does have an expiry date, and we have been replacing vials for kits in the community as they approach expiry. These kits have been also supplied to community groups such as Micmac Confederacy, volunteer fire departments with medical first responders across PEI, libraries, Soup Kitchen, SAFE program, and the Salvation Army Breakfast program. Public Health Nursing did conduct a survey in 2018 with clients who use the services of the Needle Exchange Program, and so it's an example of just engaging clients in responding to this survey. 18 clients did, and 15 of 18 said they use opioids alone. They did say that they find naloxone easily accessible to people who need it, and 13 of 18 stated they felt stigmatized as an opioid user. Information sharing around opioids for general population and harm reduction messaging has been initiated through the website, PEI, princeedwardisland.ca/opioids. A communication plan on public safety around opioids for the general public, and a communications plan on harm reduction and access to treatment for people who use drugs, including posters shared at sites like NEP, family physician offices, et cetera, and social media are examples of what we've been trying to do. Public health alerts are circulated to stakeholders quickly by email distribution, so we do not rely on just communications through the media. Education and early intervention, just to mention, we have connected with education regarding the curriculum, but we've also looked at the epidemiology and a broad approach to harm reduction and substance use. The other areas of the Opioid Action Plan are strengthening opioid replacement therapy, in terms of optimizing treatment delivery, and that's mobile telehealth service delivery and peer support, and trying to make sure we have equitable access to medication coverage. Just to note that in terms of ORT clients, there are approximately 1,100 people per calendar year, maybe a little bit less than that at any one point in time, but about 1,100 people per calendar year who are using ORT. There was an ORT Emergency Treatment Fund agreement in 2019, and Health PEI did survey the clients and overall positive response to that. In terms of pain management and prescribing practices, there have been initiated prescription monitoring reports, and I know Health PEI is working and has been working to develop a committee for this area specifically. And as an example of that sort of prescription monitoring, that if you look across it may be difficult to see the colors there, but this is really about opioid prescription dispenses expressed as morphine milligram equivalents per person for fiscal year. So we take the different types of opioids, and because each opioid has different morphine milligram equivalents. So that's a way of making sure you can compare different opioids with the morphine milligrams, or MMEs they're called. And when we do that, it looks from 2010 to 2018. And when you don't include methadone and Suboxone prescriptions, and when they are excluded, opiate prescribing based on morphine milligram equivalents has been steady in PEI since 2010, and that's the lower line. And when you see the significant increases in morphine milligram equivalents for opioid dispensing, which include your methadone and Suboxone, that is also explained by the opening of those treatment clinics in PEI in 2014 and 15, and that's where obviously a need was seen there in those 2 years. And I think it's important to mention hepatitis C in this context as well. 82% of individuals infected with HCV and PEI reported IV drug use. Our rate of HCV infection in PEI has remained steady since 2014. Prior to 2015, the rate of hepatitis C infections in PEI was higher than the national average. And in 2014, PEI embarked on a progressive approach for eliminating HCV that includes encouraging testing for individuals at high risk and providing new treatments through the hepatitis C drug program. In 2015, the HCV rate in PEI dropped 12% below the national average and did continue to decline. And in 2017, PEI reported the second lowest rate of HCV per 100,000 population in Canada. More recently, in 2019, the rate of HCV in PEI was 33 cases per 100,000 population, and this rate was not statistically different from the average rate in the most recent 5 years prior, and that's from 2014 to 2018. In 2019, a comprehensive HCV elimination strategy was initiated. The elimination strategy is planned to move to a larger sexually transmitted and blood-borne infection strategy that will encompass HIV, HBV or hepatitis B virus, and HCV, hepatitis C virus, chlamydia, gonorrhea, and syphilis. And it is expected that this elimination strategy will be revitalized later this year. As it was, I'm hoping we'll all be revitalized in many ways later on this year, but this was one of the things that definitely needs some more attention as the year goes on. Other initiatives, just to mention quickly, Peers Alliance, and they may have spoken about this earlier this month, received funding from the Department of Health and Wellness for a peer-led overdose response line. And I think they spoke to that at their last meeting. And basically, if someone is using by themselves, they can call a number, share their information, and there would be someone on the other end of the line who could call 911 if the person became unresponsive. And I know they are working to try to get that line up and running. There's also a national overdose response service with a phone as well as an app associated with it, and that was just launched in late December. One of the things that's in discussion is around vending machines so that supplies could be purchased through vending machines. So when we look at our Chief Public Health Office strategic plan, one of the priorities is to develop a coordinated harm reduction approach for reducing the health impacts of problematic substance use, and that includes tobacco, alcohol, cannabis, and opioids. So the CPHO is looking at moving to a broader substance use approach, including other substances, and that would include vaping and tobacco, alcohol, and cannabis. Harm reduction strategies for problematic substance use have traditionally been developed independently. Given that the principles of harm reduction are shared across substances, such as alcohol, tobacco, cannabis, and opioids, and many substances are concurrently used, a consolidated harm reduction approach will reduce the duplication of efforts, combine several siloed working groups, and facilitate the sharing of best practices in order to reduce the health effects from various problematic substances in PEI. Currently, harm reduction approaches such as public education and awareness, policies and practices, surveillance, and applied research vary in their application across problematic substances and would benefit from a standardized approach. Funding for such an integrated and coordinated harm reduction approach may come from other revenue streams for problematic substances. So looking forward, we are supportive in the CPHO of peer engagement and peer-led initiatives and the potential for supervised consumption sites to be part of a broad harm reduction approach. We mention increased funding for harm reduction, including needle exchange, extension site, vending machines, public needle disposal, harm reduction program coordinator, engagement of community and people with lived experience. A universal ORT or opioid replacement therapy treatment would be very important, along with continuing work with pain management and ongoing support and attention in general for harm reduction. And we mentioned, and I think maybe to just specifically mention peer support workers is something that we have not used in quite the same way in PEI, which would be important. And then I think most of the others I've mentioned up there in terms of NEP and pain management and ORT. And in terms of when I mention universal ORT, it's really making sure there's equitable access to ORT medication coverage. And because there are still some people in PEI who are receiving opioid replacement therapy, are accessing treatment through the clinic that is a fee-for-service clinic, and there were still people who are having to pay out of pocket for those drug costs. And I think I'll leave that there. And just to acknowledge the people in the office as well as outside the office, Giselle Bacher, our policy analyst with the Chief Public Health Office, Stacey Burns-McKinnon, our communicable disease coordinator, Dr. Maggie Cameron, our epidemiologist, Health PI, Public Health Nursing, Health PI, HCV treatment program, the Opiate Oversight Implementation Committee, as well as our community partners such as Peers Alliance. And they've all played a huge role in the last number of years. As you can tell, there's been work that has happened, but still lots of work to do. So I think I may just stop there because I did want to leave enough time for questions, and we understand there's another presentation following.
Great, thank you. Thank you very much, Heather. Yeah, so it's open to the committee for questions at this time. So Heath, Donald?
Just clarification before we ask any more questions, but opioid substitution therapy and opioid replacement therapy, that's the same thing? So you talked a little bit about funding in that regard, hoping to get increase in funding in that?
I think it was, I may have spoken about the needle exchange program, increased funding, but also in terms of ORT, some additional funding so that it's more universal, so that anyone who's in PEI, no matter where they go, for opiate replacement therapy is, or opiate replacement treatment does not have to pay out of pocket.
Just one other quick question. I know Naloxone, is there, I don't want to use the word vape, but I'm going to because it's lack of a better term, but I know, is there a new type of Naloxone distribution out now or do we have access to that, or is it on PEI yet?
You may be referring to the spray? Yeah, so that has been around for a while, but it is, and we can have access to it, but this is certainly the preferred method. And initially, I think both were being used, but this has been, I think, the one that has been used probably most of the time. But there are certain police services that would have access to the spray as well, because that may be easier in certain circumstances to use.
Yes, that's exactly where it came from, so, yeah. No, I'm fine for a second. Yep.
Perfect. Trish?
Thank you, Chair. So one of the approaches to harm reduction that has been discussed a lot recently is safe injection sites or safe consumption sites. And you mentioned in your presentation that 15 out of the 18 people who took the survey around opioid use were using alone. So I think that's, it's concerning, and it's good to hear that there is work going on with peers around the support line for overdose, but of course that can only take us so far. When Peers Alliance was here, they described two different models or two different approaches to safe consumption sites. One that is sort of the more traditional, longer-term model, and then a shorter-term model that can be implemented more quickly. And they gave the example of the Refix safe consumption site in Halifax. So I wondered if you could speak a little bit about the potential for that type of approach here in Prince Edward Island.
Well, and I'll let Erin jump in here too to discuss this. And we have been in touch with the Halifax site as well to get some of their experience. And they actually even changed locations in 2020 so that they have a couple of locations to be able to talk about. I think when we look at it, it's around the array of services, so that the supervised consumption sites would be put in place ideally with an array of services around to support it. And I think sometimes sort of more emergency type setups are done to immediately address a certain need. So that's the one possibility I think they were talking about, and then the sort of more broad with that sort of other services with it. And so I think in an ideal world, it would be part of that broader services that we'd be able to, that you'd ideally want to offer. Do you want to jump in there?
Yeah, no, I agree with that. I think looking at a model that would encompass more than just one option of supervised consumption and having some supports, broader supports and services available in the same location would be really important, because you have to have a holistic approach to meet people where they are. And so having that as more of a an all-encompassing supports system. I think that supervised consumption is just one piece of the harm reduction model, and without the other supports is only filling one need.
Trish?
Yeah, absolutely. I think that makes a lot of sense, and I think that we've heard about the value of other safe consumption sites where individuals can go and they can also have access to a nurse or to other counseling supports, and it can also be sort of an open door to a first step toward accessing treatment and services for addiction. So I think ideally you would want to have all of those pieces in place. What would be the next steps then to start to move this forward for Prince Edward Island to actually have some sort of a safe consumption site that would be an appropriate model for PEI?
Well, I think it starts with making sure that it is peer-led, and that it's in terms of whether it's what services are being offered as well as where, having a lot of that information from being peer-led, I think, would be really key. I do think that the potential of having someone in a role that is a harm reduction coordinator would be really, we talked about the important aspects of harm reduction and the various substances that are being consumed in Prince Edward Island. So I think that kind of coordination would be ideal as sort of a couple of the next steps. I think I'm looking through the glass there at Erin to see if there's anything else.
I'll just add, I think it's important to look at the local context and talk to the community to know what the needs are, and to make sure that we're meeting the needs of the people who live in PEI.
Trish?
Thank you, Chair. And so have those consultations begun to engage with those with lived experience, as well as those working and supporting those with lived experience to figure out what would be the appropriate model for Prince Edward Island?
Well, we did quite a bit of consultation in the development of the action plan with those with lived experience, and that was a process that was facilitated with counselors with mental health and addictions, and so that was a really good process, I think, in terms of the development of the plan. And then we've done that survey, but certainly in the last few months, that has not happened in terms of moving this forward, and I'm sure you can understand that why it hasn't happened for our office. But as we pointed out, there's some really good work that we recognize, and I think the epidemiology too it's always good. It's been important to go back and look at what does the evidence show here for PEI, and then let's reach out, and I think we may need some of those resources in place so that we can start doing more of that consultation and having that peer-led.
Trish?
Yeah, and of course, yes, public health has been very busy recently. I wonder, are there additional supports that are needed to move this forward in terms of the support and resources you'll need around consultation and coming up with, a plan and approach, and, do you need more resources?
I think that's when we talk about a harm reduction coordinator, that would be of great value. From our point of view. And then some of the other smaller bits that we've talked about in terms of just overall harm reduction funding for aspects such as, increased the services and needle exchange and the supplies that are needed there as well.
Trish? Okay. Zach?
Chair. Thank you both for coming in. I think you may have kind of answered my question when you answered Trish's question. Going back to the last slide where you had the increased funding for the harm reduction, you talked quite a bit about the program coordinator. For the increased funding, would you put more of an emphasis on one of those, or how would you weight those, or?
We didn't prepare any kind of budget for this meeting. I'm not sure I could pick one. I mean, these were the ones that we just really all think are important, that are out there. And we've talked about the extension site, which is that partnership, the needle exchange money we've talked about, just initial discussions around vending machines, which is really just the access to certain safe supplies, the coordinator, the engagement of community and people. We've talked about the universal ORT and how key that is. So I think it is a combination. It's that, like harm reduction, it's a broad approach, and so it's. I think all will be needed if we're going to do this right.
Zach?
Thank you, Chair.
Oh. Hannah?
Thank you, Chair. Thanks very much. It's nice to see you again. We're talking about the creation of these of sites, like physical spaces that were for the delivery directly to the community, working with the community. And you'd mentioned, one of those was the outreach centre, which we know is obviously it's located in downtown, which brings challenges as well, both for the suitability of the space itself, and the usual thing that happens when things are located in neighbourhoods. So I'm wondering, first of all, if you had any discussions with the municipality about how or where potential increase of support and services could be provided.
We've not had any discussions with the municipality. I think the opioid the committee on the action plan have met recently to discuss just in general what they were looking at in terms of, or what they would be putting forward as different options, and that, and again, but we aren't the right people to decide on that committee. It's really, we need to talk to people to find out where they see that consultation, and so, but we've not, or I've certainly not had any conversations with the municipality at this stage.
Hannah?
Thank you. And obviously, we recognise that this is the whole of the province challenge. That we also have some focal points where it not only is there a greater risk but also greater visibility, and so. The municipalities in other jurisdictions have been sort of key in helping to sort of make sure that the last thing we need to do is to have some, an essential service like this tucked away somewhere where nobody can actually get to it. And so, I really see that role being critical, not just in terms of hopefully financial support, to be honest, but also as a key stakeholder, as part of the solution.
Absolutely. I mean, they would be integral. I just thought you made me think that I didn't mention when we talked about our overdoses not resulting in deaths, and also our overdoses which have resulted in death in PEI, they have occurred across the province. So it's just, and those numbers again aren't huge, but we should note that they occurred in all areas of the province.
Anna?
Yeah, and thank you for that, because obviously, we have incorporating municipalities that have different abilities to be able to, and then unincorporated areas as well, but certainly the areas you've mentioned where you have kind of those extension sites and so on would have different capacity and resources, but overall some kind of mandate through the Municipalities Act to be able to be a partner in the provision of support. It does, though, circle back on that again around the funding you had spoken about, that the dollars haven't necessarily matched the need. And while I recognize again that you didn't talk about a budget, how is there a risk that or are we in a space where we're not able to meet the need because we literally don't have the resources? Is that gap there? Do you see that there?
I think when there is a need, I think resources will be found to do that. And I think especially when it's in the interest of the health of the public, and that's all islanders. Yeah, I mean, we've not made any submission to any part of government for any of these. I think it's, and that's why it's important to come here, talk about what we think are aspects of harm reduction, how we think coordinating some of the substances. Although it's about opioids, you realize how the costs of our other substances, and I think that's why I started with that it's not the only substance that's having a huge cost to PEI in every, direct costs in multiple areas. So I think that's why we come here to talk about it, and then sometimes stemming from here, we can get some policies and move forward from that.
Anna?
Thank you. And to my last question, I guess I really appreciate that kind of circle back because, when we're speaking specifically in this case about harm reduction related to opioid type substances, the huge impact that you brought up at the beginning was from alcohol, tobacco, and the health consequences there. We've talked a few times in this space about those and in other aspects as well. When I think about how many different spaces that this connects across to, and so I recognize it's not, a single budget item sitting somewhere because we're talking about health. We're also talking about education in terms of vaping in high schools or alcohol prevention. When you talked in there about a coordinator, would that be part potentially of, I guess start again, do you currently have anybody that's kind of coordinating the fact that this is such a complex and broad scope of work?
In the office, we have health promoters that are often focusing on different areas. So we have, for instance, we have a coordinator working on the smoking cessation program. We have someone who is really focused more on alcohol. We've had the cannabis committee. We have the opioid committee. But we do not have someone who is that right across the board, trying to bring all those together. And we started. You'll notice in the country they're moving, even transitioning the opiate focus to problematic substance use and harms. And I think that's that same language. So that's where we also would like to transition some of these committees to that broader problematic substance use and harms. And that's why we reference it here. Would you like to add something?
I'll just add to that. I think it's important that we do consolidate some of these siloed working groups because we can learn from each other in terms of best practices and apply some of those principles across the board, especially around harm reduction and stigma reduction. So that's with fewer human resources, we can do more that way if we combine into an overarching committee.
So is that?
Yeah. Thank you very much, Dr. Morrison. Thank you.
Yeah. Heath?
Just a couple of questions, and I should have said from the beginning that your presentation is pretty informative. I said actually, Sydney, I said, gee, we were asking her to come.
Take a recess.
So as I was saying, additional question, but I was saying to Sydney when we brought you in, I said, geez, I almost feel guilty having you here because how busy you are. But anyway, when we had Pierce Alliance in here, they really, and I fully understand the human resource and the programming and everything that we want to put a good package together to sell this to the community, the municipalities and society, but they really stress that something needs to happen now. And I guess that's kind of when we seen the tunnel and everything that COVID's put a lens on, specifically, mental health, mental illness, which is related to opioid addiction and so on and so forth. I'm wondering, should there something happen now on a smaller scale to alleviate, or I don't know the terminology, but to help this situation, because they fully got, they were basically saying the same thing that I am saying right now, is they get the programming. I think that's part of the whole package, without a doubt. But I also came from government where bureaucracy can slow things and whether it was, meaningful or not, I'm just saying, they were really prioritizing, saying, we need something now. So I guess I just want to kind of get your point of view on that. And I fully understand the other side of it, but.
I mean, I think, as with many things that related to COVID, it's highlighted or accentuated issues that were there before. And I think this is one of those examples. We talk about the fact that a special advisory committee on opioids was put in place to try to address this before COVID, and yet it seems that COVID has has emphasized in some ways, or brought out, as you mentioned, this as a ongoing issue. I think one of the things that in terms of happening now versus in the months ahead, it's difficult for me to say. I do think it's important that we're talking about it. I think it's important we're looking at the surveillance around it and continuing to monitor that. I think it's important that we start addressing it, not just around opioids, but a broader approach. Because we're looking at trying to protect everybody, and it's not just in one location. We talk about this is, impacting islanders from one side to the other. So that's why I do think knowing where and what it looks like, it should start now in terms of those really important consultation bits to more clearly identify where and what would work best for those, for the people who may be using and consuming drugs.
Heath?
Good, thank you.
Perfect. Anybody else? You mentioned, I think it was 13 out of 18 in that survey felt stigmatized. Could you talk a little bit more about that and what was done after that information came? How do we help change that?
That's a good question. Erin, do you want to?
One of the things that's really important is to make sure that we're sharing that information from the clients who did complete the survey, and because stigma will prevent people from seeking services, for coming to services such as needle exchange, going to seek healthcare services, additional supports. So it's really important that we are addressing that by communicating with healthcare providers, especially about people who are using substances, and that they do feel stigmatized, and that could prevent them from seeking supports and services that are available. So we have shared that with our opioid implementation committee and with our other stakeholders as well. And I think it's just important to continue talking about that. Before the pandemic started, we did start getting a committee together to talk about stigma, and because it is an issue not just for opioid use, but for other substance use as well, to try to look at what some of the best practices are about communicating about stigma with people, and how to and some of the root causes around problematic substance use. So it does tie into that mental health and addiction supports as well.
Yeah, and I mean, that was, like, I think we're all into that. We don't want people to feel the stigma, and if there's things that we could do along the way that can help out. Hopefully this meeting will get out there and maybe have a sense of helping that. The information was, a lot of the information was from 2017, and then I think you'd said it wasn't a crisis then. Is it moving towards that point now?
Well, when we look at, based on the numbers, we certainly have seen more overdoses that seem to have fentanyl involved in those overdoses, and that's what has changed, I think, in terms of our epidemiology the most in the last year, and so that's of concern, and so and again, it's are we doing enough to address the root causes? And are we providing enough of those range of services, from mental health and addictions to pain management? Because it's really difficult to separate any of those aspects. And just when we're talking about stigma, the other thing, just, I don't know if I said it, but the needle exchange program, of course, is an anonymous service. I think that's, people are aware of that, but that's an important aspect of that service.
We've had some great discussions on this topic. We've talked to the police force, and we've talked to the Charlottetown Police Force, Peers Alliance. When I asked Peers Alliance at the end of the meeting, I said, "How is Prince Edward Island doing on a scale of 1 to 10 with harm reduction?" And they said they gave it a 3. And just from some of the they mentioned they were excited about the programs that were put in place, the ones that you'd spoken about, but they made it clear that we're in trouble, or we're heading towards that line because of various different things. How would you respond to we talk about doing stuff with our peers or with people in the community? How would you respond, or how would you think about their comments there?
Well, I think it reflects an earlier comment I made, that I think there's been some good work that has already happened in the last number of years, and important work. Because I think you need good surveillance, you need the numbers, you need a rapid response protocol, you need to be able to put some of these programs into place. But as I also mentioned before, there's lots of work to be done. So I think we wouldn't be saying anything that would be different. Sometimes it's, when we look at all the work across all substances and know the work that has gone into the cannabis committee, and the work that's gone around the education with cannabis, and know what we like to do with alcohol, and peers may not be as aware of some of those other aspects too. So I think it's when you take them all together. But I think we would all agree that I think there's been some really good steps forward since the action plan was put in place, but we have more work to do.
Anybody else have any questions to finish off with? Thank you very much for coming in. We know that you're busy, and times are definitely changing, and we'd like to thank you for coming in. It was a great service for PEI. Thank you very much. We'll take a short break, and we'll change presenters. we're back for number 4 in our agenda. So we're going to get a briefing on the mobile crisis response units for Prince Edward Island, and I'll pass it over to our guests, and then you'll go through with your presentations. You can just introduce yourself for Hansard, and then whoever's starting off can go ahead. So I'll pass it over to our guests.
Thank you. I'm Lorna Hutt. I'm the Director of Community Mental Health and Addictions with Health PEI.
I'm Amanda Hudson, and I'm Director of Research with Mental Health and Addictions with Health PEI.
And I'm Lisa Thibeau, and I'm the Acting Executive Director for Mental Health and Addictions for Health PEI.
Okay, so I'm going to lead us through the presentation this afternoon. I just want to take a moment to thank you for having us. We're excited to share our work with you. So I'm going to start with a review, a high-level kind of overview, and then I'll get into the details as the presentation goes on. But as you can see here, mobile crisis programs are considered a best practice approach to providing mental health and addiction services to people in crisis in the community. We're actually the only provinces within Canada without a mobile crisis response service. These services provide access to stabilization, assessment, and connection to appropriate care for people experiencing a mental health crisis. And at a high level, there's 2 main components to the mobile crisis response service that we'll be talking about today. One is a teletriage crisis line, and it will be running 24/7 once we roll out, and it will be operating out of Island EMS. And then the second component to our mobile crisis response service are the field teams, with 1 in each county. So like I said, we will get into more detail as the presentation goes on. I'm just going to kind of go over some groundwork that we've established. So key objectives for our mobile crisis response include aligning our services and supports for persons in crisis with other provinces, to provide access to stabilization, assessment, and connection to appropriate ongoing care for persons in crisis, and to incorporate evidence-based practice and national standards of care into our service offering, and to provide the least intrusive, most appropriate response while prioritizing the safety of all involved. So this kind of segues us into our overview of our community first model of care. And so within mental health and addictions, we're working hard on our master plan and expanding our services. And our community first model of care is based, it's about providing mental health and addiction services to islanders in their local community. We know that clients show the best outcomes when they receive care in their homes and in their communities. And so the community first model of care incorporates a number of pieces. And so I just wanted to highlight here some examples of what we're working on. So the community first model includes our mobile crisis response, which we're here to talk to you about today. The community health centers are also a component of it. And so there's work being done on with primary care in partnership with them to have community health centers available across the province. Our outpatient withdrawal management programs are also a component of the community first model of care, so that folks can address their substance use issues at home and in their home communities. So kind of subsequent to the presentation before us, opioid replacement therapy is also a component of community first care model. And in 2020, we were actually able to expand our ORT therapy services with a new rural clinic in Alberton, as well as updated induction protocols. Just before Christmas, Bridge the Gap launched, which is a platform, an online platform which offers a number of services and resources and education pieces that are available to islanders. And also in 2020, we rolled out our 72-hour follow-up appointments, which occur post-discharge from acute mental health sites, as well as discharge from emergency departments. So when individuals present or are being discharged, they are advised that they will have a follow-up appointment with community mental health. And so this is a wraparound service that we were able to roll out in 2020. An individual from our community mental health teams will contact the patient and do a check-in, do a risk assessment, and discuss treatment planning and resources. So I just wanted to take a minute to highlight those pieces as they're crucial to our community first model of care and expanding our services. It's really about supporting families and members and keeping them well at home in their communities. So this next slide outlines a few of the expected outcomes we hope to see as a result of our mobile crisis response service. And so we have developed an evaluation framework that is based on a number of indicators. And so we highlight a few of them here. We're expecting a decrease in number of inpatient admissions, a decrease in number of calls to law enforcement, including wellness checks and follow-up visits. We would expect to see a decrease in number of visits to the emergency department for mental health and addictions-related issues. As well, we hope to see an increase in number of lives saved, clients helped, and client satisfaction, increase in collaboration between emergency and health services, and an increase in access and coordination of services for clients in need in the community. So the evaluation framework sets us out from the start to have these key indicators and a number of others so that we can get progress reports. We're looking at having one at the 6-month mark and a full evaluation of the program at the 12-month mark to really guide us in our decision making and any modifications we would need to make to the service. So on this next slide, we have some common outcomes of mobile crisis response services that currently operate. So in Huron-Perth, the mobile crisis team receives over 8,300 calls per year. 97% of the calls do not require admission to hospital. And although the volume's high, there's 4 mobile visits per day where the telehealth crisis line is able to be the primary response involved. In New Brunswick, the mobile crisis service receives over 10,000 calls per year, and 90% of those do not require transport to emergency departments. 70 to 80% are telehealth response, so with no dispatch to the field teams, with 2 to 4 mobile visits occurring per unit per day. And Nova Scotia's mental health crisis team receives over 7,500 calls per year, with 92% of them being managed by the telehealth line and not eliciting a mobile response. So as you can see, there's a high volume of calls in each of these examples with a low number requiring admissions, many supported at home, not needing transport, and many managed by the telehealth crisis line. So we do see this as a cost-effective approach, adding a level of care in the community so that the emergency departments are not the default in absence of a mobile crisis response service. So we just wanted to highlight a few documented outcomes. So youth who accessed mobile crisis services at an initial visit were 25% less likely to present to the emergency departments in the 18 months following follow-up period than youth who presented to the emergency department at an initial visit. Patients who accessed emergency mental health services through a mobile crisis unit were 50% less likely to be hospitalized during a 30-day follow-up period than those who accessed emergency mental health services through the emergency department. And in Edinburgh, they reported a 24% decrease in psychiatric admissions the year following implementation of a mobile mental health crisis program. So the next slide just gives a snapshot from 2018 of the calls that were received here on Prince Edward Island. So the information provided to us indicated that over 1,900 calls were mental health crisis calls to RCMP and police from their data. And then Island EMS, their mental health crisis calls were just over 1,100. So there would be a lot of overlap in that data, but just wanted to share that with you this afternoon. So here we're going to just kind of review our mobile crisis response model. This slide is specific to the crisis line. And so as mentioned, it's a paramedic who would staff the crisis line out of Island EMS. So we would share their command center location. And the staff would have the same training that the 911 call line staff have. And in addition to that, they would also have training in mental health and addictions, as well as a full orientation to our services. The calls that would come in through the mobile crisis line, so there would be a dedicated line that we would advertise and publicize. We would also have calls come through from 911, 211, 811, Island Helpline. We really would see them all having a direct pathway into that crisis line. And then the focus of the paramedic on the crisis line would be to triage the calls, de-escalate callers, complete client follow-up, as well as coordinate follow-up in the community if needed, educating callers about mental health and addiction services, coordinating referrals to our services or perhaps community partner services, dispatching mobile units if needed, offering team support, and completing necessary documentation for accurate data collection. And as mentioned, the full model would include running this line 24 hours a day, 7 days a week. And as per the information that I've shared so far, you can see how essential this component is to the mobile crisis response model. So in addition to the crisis line, the service includes 3 field teams, 1 in each county, with a home base in Montague, Charlottetown, and Summerside. The teams would be comprised of a mental health and addiction staff member and a dedicated officer. And, the full model includes these teams responding to calls 12 hours a day, 7 days a week. So due to staffing challenges, we're looking at rolling out a phased approach to our mobile crisis response service. So discussions continue to ensure adequate law enforcement coverage in all 3 counties. The interim phase 1 plan includes staffing the mental health and addictions mobile crisis telehealth phone line 12 hours a day, 7 days a week. We do anticipate having the 24 hours, 7 days a week staffed and operational by the end of March. But if we can get that rolling sooner with modified hours, then we would hope to do that. Planning continues for the mobile crisis units to begin with modified hours until staffing is complete, and then expanding the service as staffing allows. So we do have MOUs, draft MOUs to our partners in law enforcement, and a service agreement to our partners at Island EMS. It sits with them for review, and we're just waiting on their feedback. And so we're working collaboratively with them to fine-tune the details. There's been a few challenges along the way, not to mention COVID being one for sure, but we continue to work, and our primary focus is on getting this up and running. As part of getting it up and running, we needed to roll out a training, which we were successful in doing in January. So the training is a certification that's called CIT, a Crisis Intervention Training, and we partnered with Newfoundland on this. So we had a mental health and addictions member and a officer, both in Newfoundland, provide the training virtually to us here in Charlottetown in January. And it was a 40-hour training. Like I said, it was a certification, and it included education on mental health and addictions with a focus on special populations that we would work with. There were live role plays that were evaluated in order to complete the certification, and a number of local presentations from our community partners that are essential in our success in this service. So we had 19 law enforcement officers and 5 mental health and addiction staff who completed the CIT certification. And the model is designed based on a community partnership of law enforcement, mental health and addictions professionals, and individuals who live with mental illness and addiction disorders, their families, and other advocates. And they had a component in developing the training as well. And the feedback from our law enforcement partners was that they found it very rich and great experience for their law enforcement officers to receive. Now, in addition to the training, there were also a number of law enforcement staff and mental health and addiction staff who have been identified as train the trainers. So now that we have that certification, we can continue to train law enforcement officers across the island, because we feel it's important that whether they're on mobile crisis response as a service provider or doing their typical usual work as, you know, police and RCMP, we want them to have that education and knowledge and awareness and special considerations and how to support islanders experiencing mental health and substance use issues. So just wanted to highlight that with regards to documentation and data collection, we have a triage tool that will be used by the paramedic operating the line to ensure consistency, accuracy, and safety for clients, staff, and the public. We'll also have an assessment tool for use by the field teams for implementation for care planning and detailed data collection. Information gathered will support program evaluations and will provide mobile crisis program statistics such as number of calls, types of calls, services referred to, and call outcomes. The criteria for information sharing and protocols for documentation have been confirmed and vetted through Health PEI Privacy and our Health Information Leadership. And we have a communications strategy, and within that there are a number of communication objectives. So we want to inform the community that mobile crisis service is part of an ongoing community first model. It's a redevelopment for mental health and addictions services. Inform islanders that PEI mobile crisis response service has been implemented. To create public awareness of what a mobile crisis service is and who it can assist. To promote the public 24-hour mobile crisis phone line for mental health and addictions. To educate the public on how to access the mobile crisis service, and to engage opinion leaders and stakeholders in the implementation and promotion of mobile crisis service. And this is something that we would do in collaboration with our Island EMS and law enforcement partners. And then as next steps, finalize contracts with police agencies and Island EMS, and this includes finalizing the protocols and the procedures needed to do the work we need to do. Continue with recruitment and retention. We have a meeting scheduled to process map the call protocols, finalize schedule and coverage for the phase 1 rollout, and implement evaluation plan following the program launch. So that is the end of our presentation.
Thank you very much. That was great. Trish?
Thank you, Chair, and thank you for this presentation. So I do have a few questions. So you mentioned, at the start of your presentation, examples from Nova Scotia, New Brunswick, and Huron-Perth, I believe. So those models, are they all models where there is a police officer on the mobile response team?
So I'm going to look to Amanda for that one. She's our research lead.
Sure. So New Brunswick does partner with police regularly, although they're not dedicated to the teams. They are often co-responding in a separate patrol vehicle. Newfoundland, it's very similar to the model that we're pursuing here, where the officers are dedicated. It's a close partnership between mental health and the law enforcement agency. And here on Perth, we look to because of similarities with PEI, so very similar in terms of population density and population size. And theirs is a clinician-based team, but corresponding with officers on a frequent basis. So when they're doing calls to unknown homes, they do frequently request a separate patrol car. So it's kind of a co-response in that type of partnership.
Trish?
Okay, that's really interesting. One of the questions that many of us have had around the implementation of the mobile units here in PEI is, why was it decided to, go against the recommendations of the steering committee in having, police be a core component of the teams in every case? So you just described, a couple of other models where the mobile crisis teams might collaborate and work with police, and sometimes police would come if it was deemed to be needed. But it sounds, that's very different than what we're talking about here. So why was that decision made, or what went into that decision?
So the recommendation from the development team, I think you're referring to, it did involve 3 agencies partnering, so it would have been mental health and addictions with law enforcement as kind of ad hoc partners, being a co-response when required, and with Island EMS, where paramedics would have been ride-along partners to provide integrated care. And that model was actually quite well received by the executive leadership team at Health PEI. So there was a lot of positive feedback. A lot of elements of that recommendation were retained in the current model that's being pursued. The main difference is that, as you mentioned, officers will be dedicated to the teams rather than a co-response as needed based on triage. And I think the reason for that is we wanted to prioritize safety. So executive leadership said, safety is a priority. We want to follow suit from other Atlantic provinces and use an evidence-based model that's similar to our neighboring provinces, which have had very positive outcomes, good evaluations. And I will note that in the recommended model, when police would have been a co-response, that would have been in a patrol car with uniformed officers. So in those cases, it would have been more of an intrusive response than if we had dedicated officers in the teams responding in the mobile crisis vehicles, which are very discreet and less intrusive.
Trish?
And you mentioned sort of aligning with our neighboring provinces, and unless I misunderstand, it's Nova Scotia has this similar model, but you described Newfoundland and New Brunswick as more of a like a partnering sort of model with police, or that. So it doesn't sound like it's necessarily aligned with all of our neighboring provinces. And across the country, we are seeing a shift, right, away from the models that, like the one that we're implementing brand new here in Prince Edward Island with police being a core component of that team. Like in Toronto, for example, they've moved away from having police as a core part of that team. So I guess my, question and concern around our, newly implementing this program using what seems to be an outdated model. What about consideration of best practices? It wouldn't seem like this would be the most appropriate approach at this time.
So nice summary of the different models. I will just clarify, I don't know if I spoke to the Nova Scotia model, but it is very similar to what we have here. So it is dedicated officers partnered with mental health clinicians, similar to Newfoundland. New Brunswick is where they're separate agencies, but they do partner and co-respond on a very regular basis, especially in the Moncton area where it is almost 100% of the calls would be police and mental health co-responding. If we look to there's a wide range of models. There's very, different elements to the models. If we look to BC, some of these mobile crisis units are law enforcement led or law enforcement based. In Toronto, that was previously the case, and there have been updates to that model. However, there are still mobile crisis teams in Toronto, which are law enforcement based, partnered with mental health professionals. So there's a wide spectrum of models. And I'm familiar with what you're saying around the best practice recommendation that came out of KMH recently. I agree we have to be continuously monitoring the upcoming models and the latest research, and we certainly will do that. We are dedicated to providing evidence-based services to Islanders, but what we're doing right now is implementing a model which is evidence-based. It's consistent with other Canadian jurisdictions that we've looked to, and evaluations have been positive.
Trish?
Yeah, and so you mentioned the evaluation framework. You've already developed that. So how will your evaluation framework evaluate the role of police specifically on these mobile teams, and whether or not this is or is not the best approach for PEI?
It's an excellent question. I did bring a copy of the evaluation framework in anticipation of that question. So we'll be looking at a number of different indicators, including the indicators that Lorna presented on, hoping to see reductions in emergency department visits, reductions in inpatient admissions and lengths of stay, in reductions in patrol cars, so police officers responding kind of solely to mental health calls. And we are going to look at number of calls that are managed solely by mental health versus number of calls that are managed by police combined with mental health, so like a patrol combined with our units, versus calls where EMS and mental health mobile crisis are required. So we can look to see what are the nature of these calls, what are the outcomes and the responses that are being directed to these calls, and do we need to tweak this model? So we will be checking in at 6 months and at 1 year, and we'll be monitoring this ongoing throughout that time course to see if we're matching services to the needs based on the types of calls and the types of responses.
Trish?
Thank you. And will there be any capacity to track or account for, whether or not the police officer was required as part of that call? So in terms of who's taking the lead within the mobile mental health crisis team at a situation, so that we can assess whether or not that really is necessary from a safety perspective.
So our triage form and our assessment form, which are documented on our health information systems, those will collect information regarding risk levels, regarding the category of call, so it's a specific mental health or substance issue that was being responded to, and that will give some of that information. I do want to say mental health and addictions are the leads on this, so police are an important partner, EMS is an important partner, but it is a mental health and addictions led initiative, led program, very much a health response for a health issue.
Trish?
Yeah, absolutely, and that is very good to hear, and is certainly most appropriate, I would think. So along those lines, though, then I would expect that the mental health and addictions staff that are on the team would be the ones who would generally take the lead in a situation, and then should a police support be needed, then they would step in and be a part of it. Would that be fair to say what the recommendations would be in terms of how these teams would work?
The recommendation is that the mental health addictions professionals would lead the assessments, would lead the care planning, the referral coordination, so they would very much be leading all of those aspects. Police would provide risk mitigation if that was required, and police also have special skills in terms of de-escalation and kind of risk assessment, so in that way it would be a partnership.
Trish?
So this is a very, in perhaps a little bit of an in-the-weeds question, but I think it's going to be really important to track this information as well as part of your evaluation framework. So, keeping track of when, the number of cases where the police were or were not needed on that, at different calls. Because, if we are being genuine in recognizing that this model, is not the only model out there and is in fact, one that has been recommended as not best practice by some, at least, we have to consider that it may not be the best approach. So I hope that that's something that you'll consider tracking in that model. I do have a few more questions, if I could. The three teams, so there's going to be one based out of Summerside, one in Charlottetown, and one in Montague. So that will involve, you said RCMP as well as city police for Charlottetown and Summerside, is that correct?
Yes, and Kensington as well.
And Kensington as well, okay.
Do you want, just ask maybe one more question.
Okay, it's related to this, it's a part of the same
sure.
question, but fair enough, yeah. So how will that work in a practical sense, just to make sure I understand? So for example, the Summerside team with a Summerside police officer on the team gets a call, to go to O'Leary because there's a crisis. So the Summerside police will be working outside of Summerside?
And these are the finer details that we're working through, but as per the Police Act, they have the ability to do that with the appropriate MOUs in place. And so that would be exactly how it would work. So if on a certain shift there was within the Mobile Crisis Response Service, it was a Summerside police officer partnered with our mental health and addiction staff, they would respond to anywhere in Prince County.
Great. Good, perfect. Sydney?
Thank you, Chair, and thank you so much for your presentation. I think we all share some of the concerns that Trish is raising, but the bigger picture is this is so needed, and I'm happy to hear that we're not waiting until everything is just perfect to roll this out and that it's happening. But we do as elected politicians, we get these questions. So can you walk me through exactly how the team is going to present, and specifically with the police presence as well? Give me I know there's no typical example, but walk me through how they will present, from call to coordination with the team going forward.
And so some of these details are still being worked out, but if we went with the example of a call coming through to the crisis line and that paramedic taking the call, triaging as needing an in-person response, they would then dispatch the van to the home location, for example, and then upon that arrival, they would together, the police officer and the mental health and addiction staff would, enter into the home. The police would do their duty and their role of kind of assessing safety and security for everyone, and the mental health and addiction staff member would, kind of screen and assess, find out what's happening in the moment, what that priority need is. They'd have a lot of that information already from the call. The paramedic on the line would have been gathering all of that really important information, and also accessing, our data networks in order to see if there was any relevant history or anything that needed to be considered before entering into the home. And so upon, the service, they might decide that that person is well enough to stay at home and their needs are met that way. It might mean connecting them with the service or a referral to our community partner or one of our existing services. It might mean perhaps they need acute care, but these can be this can all happen in that person's home versus them coming to what most likely has been happening is going to emergency department, right? And then following that call, that visit, depending on the outcome, when the person does return home, that team could also provide follow-up, which is something I didn't mention in my presentation. So I missed that piece, which is also very important to think about the number of follow-up calls and follow-up visits that the crisis team can provide as well in order to keep people well and at home versus moving into a more acute or inpatient situation.
Sydney?
Thank you, Chair. Thank you for that answer. And I know we've all seen the videos, of mental health responses where, perhaps an armed officer, was abrupt coming into a home. And I think that's, a lot of this concern, or just not handling it. So when you say the mental health experts will be the lead, will the team present all together? Will it be decided on the way, like who's going to show at the door? Would it be just the mental health lead approach a door at some times, or is there a policy that everyone goes together?
Well, policies aren't in place yet. Those are pieces that we're working out with each of the law enforcement agencies. So I can't say specifically, but I would anticipate that there would be, based on the information that they have, that decision could be made. But the police officer's role is also to ensure everyone's safety. The training that we provided through Newfoundland was really about that education piece and not, coming in abruptly, those considerations around peaceful visits and whatnot. Was there anything else, Amanda, you think we should mention on that piece?
I think that you covered that really well. I would say current state police are a primary point of contact for mental health calls, as we know, and this mobile crisis program is going to be a huge advantage over current state in terms of the specialized training, the partnership with these knowledgeable mental health and addictions clinicians. I think it's a big step forward.
Sid?
Thank you, Chair. And I appreciate, how we're going from, like we're not doing from one extreme to the other, and there's a gradual approach to this. Back to Trish's point, I'm glad to hear that, there's evaluations going to be happening ongoing, but at the 6 months and 12 months. And as far as the triage forms and the tracking the police involvement, as she had mentioned, what's going to be, I guess, released to the experts like you all, but also to the public or to us as legislatures to monitor that. How much of that will be available to be monitored, the public information of that?
From my perspective, I think it would be appropriate to share the 6-month report and the 1-year report publicly and with key stakeholders. I think that's important information, and we want to be transparent and share knowledge.
Can I also add that as we do these evaluations and these visits, that it's really important that we'll also be connecting with the clients and families who are using those services to get their feedback as well.
And we should also mention that there were patient focus groups that were conducted prior to this work as well, that Amanda was the lead on.
Yeah, exactly. We consulted with patient advisors, with family advisors, and that was a key part in planning for this model. So no model was presented or recommended without that patient lens.
Sydney?
Thank you, Chair. I think that's important, you know, to, especially for those of us that might have, you know, concerns about, you know, that response. And I appreciate that that's what we're doing now, you know, like, and no doubt there's some very successful responses right now. But I just think it's so good news that this is finally going to be rolling out, and I appreciate all the work that you all have put into it as well. Thank you, Chair.
Thank you.
We do see it as very much an enhancement to our current services and are very excited to, you know, see this happening. A substantial amount of work has gone into it and has been a focus of not only our leadership group but our frontline staff as well. So it's exciting.
Sure. Sid?
One more thing, you know, I think that it'd be wise for the committee to keep following up to check in on those annual, or not annual, but whenever those reporting periods are that this committee here. So, thank you.
Zach?
Thank you, Chair. Just to echo what everyone said, thank you very much for the presentation. I think agree with the other members that it's something that's definitely needed. Just one quick, or maybe two quick questions. The first one, maybe I was mistaken. So the original phase one rollout is 12 hours a day, 7 days a week. Is that correct?
So we haven't finalized the hours just yet. We're waiting for our the response back from our law enforcement partners as well as Island EMS. The rollout of the phone line is on a track for the end of March, and that'll be 24/7 by then. If we can roll it out sooner, then we would be looking at the 12 hours a day, 7 days a week for the phone line. And so until we get the MOUs back and they're finalized with our law enforcement partners, we won't know the hours just yet.
Zach?
But would anticipate it being the full model when it's all completely staffed and on the road will be 12 hours a day, 7 days a week for the field teams. I anticipate a modified version, like a 5 days a week, 8 hours a day, not necessarily business hours, but until we can reach that full model.
Zach?
Thank you, Chair. The last question I have, I guess, is I was actually really curious about, you mentioned at the start that it's, you know, a bunch of different things you're putting into place, and you mentioned the Bridge the Gap being released, I think, at the start of the year. How has that been accessed? How has it been received? Do you have any stats or any numbers on that?
We do have utilization stats, so roughly 1,000 new users per week since it's been launched December 23rd here on the island. So really good uptake, and I think indicates a need for that, for those types of virtual services and supports.
Zach?
One follow-up. Thank you, Chair. Is there a part of the website or the app that people are more focused on, or is it more just a kind of a, I'm curious as to what this is?
There's many different aspects. So there's service directories that help connect people with the specific services they're looking for. There's education, there's resources. There's a federal webpage where there's a link to that, which offers different types of peer support programming and clinician-led programming. There's also online programs for anxiety, as well as children and youth programs through our partners at the Strongest Families Institute. So there's many different elements. I don't have the stats broken down by those elements, but it's quite an array.
Okay. Heath?
Yeah, just, I was going to ask about Bridge the Gap and the statistical information too. I was actually in on it there not too long ago, and I was just checking it out. But it is a good resource. I'm just wondering, like, who is leading the mobile mental health, and like, who's leading this? I know you guys are here leading, but is there a director or manager, or like who's the backstop? So if questions whenever down the road, I'm sure obviously you're very busy, so.
So we have a team lead, Dr. Jonathan Dudek is a psychologist, so he is the team lead for the field team and is working collaboratively with Island EMS and law enforcement. And then he reports up to myself as Director of Community Mental Health and Addictions, and then I would report up to Lisa as the Acting Executive Director of Mental Health and Addictions.
So all the staff are in place for this?
No, they're not.
No, they're not. Okay. Just a question in regards to the police. So are they going to be working for Health PEI, or are they going to be off-duty officers, or how does that?
The police, sorry?
Yeah.
No, so they would remain officers of their home agency, but committed, dedicated to mobile crisis response service. So they would be hired specifically for our mobile crisis response service.
So you're hired?
No, they're hired by their home agencies, police.
No cost to Health PEI for them?
So they're under the funding budget, the model, there would be funding coming from Health PEI in that, yeah.
Heath?
Thanks, Gord. So the expected outcomes that you had on your slide there, obviously, is there a cost analysis on the benefits of those expected outcomes for Health PEI? So if this progresses and works very well, what is the savings to Health PEI on those cost analysis?
I don't have precise values to that, but we know that right now we're seeing about 4,000 emergency department visits per year for mental health and addictions, and that's very cost intensive. It's also clinically not the most effective place for some of these folks to be getting care. So I think it's both cost effective and clinically effective to implement this program, and it addresses a gap along our continuum of services, as Lorna mentioned. Right now, often emergency departments may be the default, and this is just an important kind of intermediate level of care that is going to be cost effective and clinically effective.
Heath?
So when we talked about the timing, and you talked about 8 hours or 12 hours or whatever it is, and obviously in the public you've heard, why are we not doing this 24/7? Is there a specific reason for that? We're not doing it 24/7, or will not be doing it 24/7, or what's the end goal, I guess?
Well, I would say that the full model of anticipated 7 hours a day, 12 hours a week was based on call volume that from the research that had been completed early on, with the highest volume being from noon till midnight. So we're looking at those hours as being our primary focus. With regards to it being outside of that, I think it's important we run with what we have and evaluate and see if the need is there. I think that people are still going to need help outside of those hours, but this is a starting point.
Heath?
Fine, thank you.
Great. Hannah?
Thank you, Chair. I guess the context for my question is that we have been talking for months about the staffing challenges that are in healthcare overall, and the ongoing challenges in providing mental health services within our existing system. And I'm hearing, I've obviously heard how important it is that we have crisis response teams, but this is in addition to existing programs and services, because you don't have enough data to be able to sort of say how this could potentially replace. And so with that kind of context in mind, there's some very large gaps in what you've presented for us today. I mean, the initial press release for this in terms of when they were ready to roll was going to be in the new year. And I understand, you're working towards this March piece, but some of these gaps are like personnel gaps, training gaps, MOUs, financing agreements. These are not small things to get done in 6 weeks. And so I'm really concerned that we've gotten this kind of fantastic project with evaluation frameworks and surveys and things, but we don't actually have the people who have the right skill set. So I can see a couple of things coming. One of them is it gets delayed again, which is probably better than rolling something out that isn't staffed appropriately or isn't actually meeting a need. And I guess my second part to that is crisis does not happen in business hours. Crisis, to my colleague's point, can happen at any time. And when you have 4,000 emergency visits, that's the data that tells us that how much of a crisis we have, because we know that people don't even go to emergency. Those are only the ones that go there. We don't have, to my understanding, a contact point for people to go to. So I guess with all that context, it's a question for Lisa, which is, how does this integrate, or how can you integrate this into longer term supports and services so that you're not continually cycling in crisis? What's that integration going to look like, and how does that play out, given some of those challenges that we have?
Yeah, I agree. I mean, staffing has been an ongoing challenge. For this particular program, we've actually been able to recruit several people from out of province, some who have worked in similar programs in other places to come back to PEI to work in this program. So that's really great that we have some people with some experience, and the rest of the people, we're training up. As we move forward in our master plan, the hope is that things will shift, right? And sort of like Dr. Morrison talked about, sometimes it's about realigning those resources to provide different services. And so that is our hope, that if we are able to provide the gaps in this continuum, and really, this mobile crisis will really address multiple needs, that we would hope to then see that shift, that we could start realigning some of those other resources.
Hannah?
Thank you, Chair. So one of the challenges when you want to spin up a new program is that you have to run your existing programs and spin up the new program, which creates sort of a double capacity, particularly when you've got something which is high risk. And so there's a couple of things that I was wondering if you could speak to. One of those is what your gap analysis is showing you when it comes to sort of your immediate pieces that you want to try and address, and then how that reflects into the bigger picture of how we provide mental health services, because we already have gaps. And so I am really concerned about, the surveys will only tell us so much. So when we actually get into that real world and we begin to sort of see what new gaps we identify, and we don't have capacity in our system as it is now, we're not going to be able to deliver on what we need to. So it's a real concern. And then the other piece is associated with that. What is your risk analysis? What risk analysis and mitigation do you have in place if you find that there is way more out there than you were expecting, which I really feel is what's going to happen?
So I think there's a big risk in us not doing this program, because we know that people are being harmed by not having this service, and it provides good care across our, other provinces. And so there is a risk of us not doing that. However, I hear what you're saying, that we often put new programs in place thinking that we're going to, reduce a wait list or meet a need, and we often find an unmet need. So I think part of the challenge for us is being able to be fluid as we evolve in this master plan and realigning our services to make sure that we are using evidence-based programming, and we're looking at that data and evaluation to make sure that we're really able to address those spots that maybe we hadn't realized. And again, I think we're hopeful that there'll be some of that realignment of resources. And I think things will evolve. As much as we have a really fantastic plan, we cannot predict what's going to come to the future. Substances change, circumstances change. COVID came, and creates different challenges for us. And so really it's us about creating a system that can also be really nimble to respond to whatever presents to us.
Hannah?
Thank you, Gord. Thank you, Chair. Sorry. That's one of those days. That definitely is the concern around the gap in recognition of that. I think my challenge I have when I hear from people who are in crisis now is they go to an emergency department where they may sit and wait with everyone else, which you do in an emergency department, and they're not being treated because the resources aren't there. So whether it's the wait, or it's that the beds aren't available, or there isn't a psychiatrist available for an assessment, or whatever that may be. And so I am really failing to see how being able to respond with a mobile unit, which may include somebody who could create actually even more trauma or distress, is going to, where are they going to go? Because we don't have that delivery of service now. So I'm not seeing that bit in this story that recognizes that we're actually failing to deliver on the receiving end now. I can't see how this is, what we're going to be doing is basically picking people up and giving them a free drive in a scary van versus sitting in emergency for 8 hours and then being sent home.
So I'm going to speak to a couple of things on that. Again, based on the numbers of our partners across the country, our hope is that very few people do get transported, that most of them will be able to support the clients and their families in their homes. As far as the emergency room, one thing that we're working on is, well, there's two pieces, is we are working with the emergency room physicians to change the process so that when people are triaged, if they don't have an immediate physical need, then they can come right to us. They do need medical clearance at some point, but in the past, they would have to wait for that medical clearance before seeing our crisis nurses, which could take hours. So we've actually made an agreement with them that unless there's an immediate physical need, that they would come through our service first, and then we would be able to work with them with psychiatry, and then at some point in that encounter, the medical doctor would come give them a medical clearance, but it wouldn't hold up that process, so people should be able to flow through much quicker. The other thing is I checked with our project management office, and they have put out will be putting out the RFP very shortly for an architect to design. We're going to be adding a piece right onto the emergency room, so that we'll have a short stay unit with 4 beds, so people could stay up to 72 hours if they're in crisis, and we can get them settled, but also have that more robust team. So we're actually adding to that team right now because we have a crisis nurse in there. We're adding an additional crisis nurse as well as a social worker and an LPN to make sure that when people are presenting, we have a full team in addition to our psychiatry and then, of course, medical services.
Can I just add one thing to it? It's not just crisis resolution, it's also crisis resolution and care planning and care coordination. So the hope is that whether it's a telehealth response or a mobile response, that individual will have kind of a needs assessment done and be connected, whether it's community mental health or whether it's coordinating with an NGO or a community partner. So referring for grief support or victim services, or referring to community mental health or addictions, that there is that follow-up piece beyond crisis resolution.
Can I also add one more piece? The other piece we're really struggling with, and we need to find a better way to do it, is to communicate to the public what we actually do have for services. I often have people come in and say, this is what I'm looking for, or, I'm being told there's no service. And then when we explain the huge range of services we have, they're often shocked that we have services across the island and a fair continuum that we're then continuing to build on. So I think that's also an important piece so that people really understand there actually are, comparatively, I've lived in other provinces, and for being such a small province, we actually have a fair amount of services. But if people are not aware of them, they're not going to reach out to access them.
And just community, we'll try to finish up within 10 or 12, 15 minutes.
I'll just finish this one.
Yeah.
Thank you, Chair. I really appreciate that answer, Lisa. It's really refreshing and helpful to hear that you are recognizing that experience, and have plans in place for it, because it's on the other end of that. It is a genuine worry. We are genuinely concerned of we're one day away from it going horribly wrong, because every day we get, as you do, the calls and the experience. And I think part of the education piece is how challenging it is to change that narrative of how scary and difficult this is. It's hard enough. Stigma is not just how people feel about it personally, but what their community tells them this is like. And I think in some ways, when I circle back to some of the conversation we're having about police officers being involved, that's some of the challenge there. It's the perception and the message that sends, whether or not it's needed. And I absolutely understand there are absolutely spaces where it is. But that navigation and education is going to be pretty entrenched, because the experience has been really hard. And it's been shared publicly, and it's been repeated. And so the outreach education piece is it's got a lot of barriers to come over it, but I do really appreciate hearing that there is a path to identify that challenge. I still am super concerned about the timeline and just worrying about that timeline. And I know that projects like this are so complex. I can't imagine how many moving parts there are. And my question, I guess, my last question, Chair, would be, in the interim, until this can spin up, given that maybe there might be a little bit more of a delay, what can we do? What can we have in place that will recognize that this is happening right now every day? What can we take from the work that you've done that allows us to provide better triage or to provide better intake right away before the crisis team is in their space, because that need is not new? I don't know who that's to, but that's my question.
I would say that these calls come to us now. You know, granted, they are typically, you know, in our community setting anyway, during business hours, and we do what we can to respond. We have specialized teams, you know, our generalist practitioners, we have our outreach teams, and we partner with our community partners to do home visits where we can, and, you know, have excellent working relationships with a number of folks, and we partner along with the interdisciplinary bridge program that exists already to, you know, access and assess the risk that is being put forward on those cases. So, and that's all off the side of the desk of what our folks on the front lines are doing now anyway. So, you know, in the interim, we keep doing the best we can. We collaborate, we communicate with our community partners, and just continue to build those relationships. You know, we're working to enhance our walk-in clinic hours and expand those services, and recruitment and retention is just such a crucial and huge focus for us. You know, I don't know if there's anything else you guys want to add on that piece, but, you know.
That's good. Trish?
Thank you, Chair. So, you know, just a few more questions about, you know, capacity at the QEH emergency department. So it's really, you know, good to hear about plans to build additional capacity for mental health. I believe you said 4 beds, and actually building on a separate space. So that's really good to hear. And I just, you know, I did want to highlight, or I had a question along these lines actually. In fact, Dr. Trevor Jane had tweeted that the QEH emergency department had the largest inpatient ward and particularly inpatient mental health unit in the province over this past weekend. And I thought that was surprising to hear. So how many, you know, inpatient mental health, you know, how many do we have at a given time in the emergency department in QEH? What are the numbers there?
The numbers can fluctuate. We could have 0 people, we could have 5 people, we could have 7. I think around 5 to 7 is about the average if we had a busier day. But again, we can't predict, right? We could have a day where it's very quiet and the next day could be very busy based on various circumstances. I'm not sure how many numbers he had at that time, but you know, Hillsborough has psychiatric units that would have higher numbers than that. So I'm not sure how many would have been in on that particular day.
Trish?
Yeah, and you know, I mean, I'm not sure, you know, where what happened in that case over the weekend, but I would have suspected that the numbers at inpatient at Hillsborough Hospital would have been much higher, if not at Unit 9, which is of course not at full capacity. So that, you know, it is concerning to see that. So it would be good to get some more information about those numbers. Again, I'm glad to hear you're increasing capacity, but if we're talking about a situation where the QEH emergency department, at least on one instance, had the largest inpatient, you know, numbers in the province, and perhaps in more than one instance this has happened, then we have a much more serious problem than 4 beds is going to solve.
So again, I'm not sure what he's comparing it to, so I can't say for sure.
Trish?
Thank you, Chair. So just going back to the focus groups that were conducted, the consultations before the deciding on the plans for the mobile crisis unit, would it be possible to get the report from those consultation focus groups?
There's a presentation, and yeah, I'm happy to share that.
Trish?
And does the presentation include the methodology of the focus group and the you know, questions that you asked and all of that information?
Part of a larger presentation, but I can provide that detail as well.
Thank you. I would love to see that. Thank you. As well as a copy of the evaluation framework, which I know you have here, so I'd like to have that also. You mentioned in your presentation about phase 1, but I don't know, could you elaborate on how many phases you have planned and what the expected timelines for those phases are?
They haven't been determined, so the full rollout of the phone line would be 24/7, so that'll be completed by the end of March in So there's no issues around the staffing of that. It's really just the service agreement and getting that signed off on. It's the field teams where we're anticipating, an uncertainty around rolling that piece out, so I can't say for certain. The full complement will be 12 hours a day, 7 days a week. But until we iron out those details with law enforcement, I can't say for certain.
Just one more question. So you mentioned you have conducted some training with, I believe it was 19 law enforcement and 5 mental health and addiction staff, as well as there was a mention of some new staff being hired from other provinces who have experience with mobile health. Could you tell me how many new staff have been hired and how many you will need to move this forward?
Yeah, so the crisis intervention training is focused, it's a law enforcement training on mental health and addiction. So we had our 5 mobile crisis response mental health and addiction staff attend that training. And so we have the team lead has been hired. We have 1 staff in Summerside, 2 in Charlottetown hired, and unfortunately 1 who was hired in Montague recently moved into a new position. So we completed a number of interviews last week with offers pending, and actually have an interview again tomorrow afternoon. So we're actively recruiting those into those positions.
During November 4th interview, Werner Ryan did say that it was going to be in early 2021 with 12 new mental health professionals. Is that still, are you still looking at 12 for the?
So there will be 9 field physicians.
Yeah.
A medical secretary, a team lead. What am I missing? So that's 11. Not sure.
Yeah, that's all right. So March, you mentioned end of March, the phone line opens. Is that when your evaluation will begin?
Yes.
Okay, so then the evaluation will obviously when more and more pieces come on, the evaluation would change.
Exactly.
If you go through the list of things here, finalize contract with police agencies and EMS, when will that be completed?
It's sitting with them now, so I don't know. I know that they've passed it on to their higher ups, and they're just waiting for confirmation. There weren't any red flags with Island EMS. The police agencies, given that there's municipal and RCMP involved, have more details to iron out. So I anticipate that one will take a little bit longer.
Yeah. And your continuing recruitment and retention keeps going. The process map call protocols. So that's just, I
It's
guess.
in process. Yeah, exactly.
Yeah. That's a concern when I see phase 1. It would indicate that we would know how many phases we have. And I don't know if we do know that. So it's just, I'm kind of concerned. I don't. Yeah.
Fair enough. I would say that our interpretation of it is that the full model is the 12 hours a day, 7 days a week in the field, and the 24-hour line.
Yeah.
The phase 1 language that we've been using is, in the interim, as we have people hired onto this and the phone line goes live, what can we provide? Is it a Queens County response? Is it Queens and Prince? But those pieces are really dependent on the MOUs and because that also dictates the staffing on those for those agencies.
I really appreciate you coming in, and I guess some of the information that we've heard before would maybe not match what we're hearing today a little bit, and I guess that's where some of my concerns would come from. But the process of the spirit of what you're doing is going to be great. So does anybody have any other questions at this time? Good. Thanks, Lorna. Thanks, Amanda. Thank you guys for coming in, and I appreciate it, and Lisa. And we will take a quick break, and then we'll be back just to finish up the meeting. we're back to move on to number 5. Just a few things to talk about with the discussion of scheduling coming up. I was just talking with the clerk about that. The meeting will be scheduled for the 17th with Minister Compton to talk about some of the issues that we talked about with the ALC, the gambling component. So make sure you keep that. It's next Wednesday. So the clerk did hear back from, there was a request, a motion put in to bring in Minister Thompson to talk about his report. Do you want to give him some dates with the 12th?
The only correspondence that I've really received so far, just in the back and forth, is that as of today, the deputy has said she will get back to me soon, so I don't have anything really to pass along except for that. They do, however, know that the committee will have to know 24 hours in advance of the meeting being scheduled, so the 12th is an option that they have right now, Friday. So if they choose that one, we'll have to know fairly soon. And the only other option that is available is either the morning or the afternoon of the 17th. So I have yet to confirm, but I'm supposed to hear back soon.
So the 12th is Friday, so we'll wait. If we hear about it tomorrow, that will be a quick turnaround time. So, and if we're talking about, do we know if the 12th is morning or afternoon?
I believe it's an afternoon.
Okay.
We would not be available.
Okay.
We have a caucus meeting already booked and planned for the 12th in the afternoon.
Okay.
So we would only be available in the morning.
I think I have both the morning and the afternoon open to them, but I can clarify to, yeah.
Perfect. It's good to know. Okay, so we'll look for the morning of the 12th. Other than that, I think we're all set with the scheduling. Perfect. Sydney?
Sorry, did you say February 12th morning?
Yeah.
So we have previously let, I thought most chairs and clerks know that our caucus is unavailable the 11th, the afternoon, and the morning of the 12th as well for caucus.
Okay.
And one more question.
Yeah, sure.
So you say you have a meeting booked next week as well?
The 17th?
So this committee is not thinking about the planning week before the legislature at all? It's still planning meetings for that week?
We talked about that last week, and I think I think we're starting 2 days later, or the 26th. So we're okay until the.
Not a week of planning days, it's just they start later because
Yeah.
of the sitting starting later.
Yeah. Yeah. Great. Excellent. So that will probably take care of the 12th is not an option.
So we'll hear about the 17th.
Yeah. Exactly. Okay. And if we hear any other correspondence, we'll let you know, and as soon as we get it. So at this time, any new business? No. Okay. Can I have a motion to adjourn? Trish, this meeting is adjourned.